Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Surgeon Influence on Use of Needle Biopsy in Breast Cancer Patients, a National Medicare Study, by Jan E. Eberth et al. My name is Susan Harvey, and I am the Director of Breast Imaging at Johns Hopkins Radiology in Baltimore, Maryland. My oncology specialty is breast imaging. Healthcare payers, including the government, are moving towards systems based on quality and cost-effectiveness of care. In the complex setting of traditional practice patterns, reimbursement pressure, and the drive to provide the best care at the lowest cost, it is critical to carefully assess what we do, why we do it, and how we can do it better. The article that accompanies this podcast demonstrates how this has been done for the diagnosis of breast cancers and is important work that should have a significant impact on patient care and practice patterns. Since the 1990s, it has been well documented that in skilled hands, breast needle core biopsy has the same diagnostic accuracy as surgical excision. Equally well documented is that needle core biopsy is more cost-effective, less expensive, and leads to less morbidity. Despite this published evidence, the utilization of breast needle core biopsy in the United States remains strikingly low, on the order of 50 to 60%. How could it be that we have this knowledge and yet data shows care is not provided accordingly? As one would expect, there are several factors that explain and influence this patient care pattern, as well as options for improvement. The article by Jan M. Eberth, Ph.D. et al. Explores these questions. The recent development of a national cancer cohort allowed the team to review Medicare data for women who had been diagnosed with breast cancer to assess the use of needle biopsy in their care. This review provided data to assess physician characteristics and geographic factors that either impeded or facilitated utilization of needle biopsy, and then related this to the number of surgeries patient underwent and quality of patient care. The methods used to gather the cohort were from Medicare claims for breast cancer treatment services related to breast conservation surgery and radiation, as this is the population most likely to benefit from breast needle biopsy diagnosis. Between 2003 and 2007, there was data on 89,792 breast cancer treatments. 3 outcomes were evaluated. 1, timing of surgical consultation before or after needle biopsy. 2, the use of needle biopsy, which was a yes or no, with needle biopsy defined as fine needle aspiration or large core needle biopsy. And 3, number of surgeries before radiation treatment. In addition, the distance that a patient lived from a radiology facility performing needle biopsy was assessed using zip codes to review the impact of distance on utilization. Also, surgeon characteristics such as years of practice, board certification, and others were gathered. Appropriate statistical evaluation was performed. The review of data showed interesting results. Of the 89,742 patients, The median age was 74 years old. 60% of patients lived within 3.4 miles of a radiology facility that performed needle biopsy, and 90% lived within 18.9 miles of such a facility. 68% of these women underwent needle biopsy. 93% were large core needle biopsies. The utilization of needle biopsy increased over time, 61% in 2003 and 77% in 2007. Geography was a very important factor in needle biopsy utilization, with Bismarck, Nebraska being the lowest at 21% and Lynchburg, Virginia the highest at 97%. 68% of women who saw a surgeon in consultation before needle biopsy. Of these women, 46% did not have a needle biopsy. 38% had a needle biopsy performed by their surgeon, and 15% had a needle biopsy at another facility, typically by a radiologist. Patients who did not have needle biopsy were more likely to be older, in their 80s, poor, Black, ill, living in rural locations, and farther than 8 miles from a facility that offered needle biopsy, and to not have had a mammogram before surgical consultation. The use of needle biopsy was strongly influenced by features of the surgeons. The surgeon characteristics associated with a lack of needle biopsy included lack of board certification, training outside the United States, greater number of years since training, general surgeons as opposed to oncologic surgeons, and low case volume. The lack of needle biopsy use led to a higher risk of multiple surgeries. The likelihood of multiple surgeries before radiation treatment was 70% without needle biopsy and only 34% with needle biopsy. These results show that providers influence patient care more significantly than geographic location. The surgeon characteristics heavily outweighed the distance from a facility offering needle biopsy. This implies that improvements in quality of care should be focused on the providers rather than payments or other incentives that are based on geography. The results show that increased utilization of needle biopsy can improve quality of care and can be influenced. Educating and empowering patients and primary care providers to seek care and partner with diagnostic radiologists is an important goal. Additionally, improving access to radiology facilities may be helpful, as when patients live more than 8 miles from a facility, they underutilize the service. Increasing the surgeon's use of needle biopsy is unlikely to lead to improvements in care, as there is literature showing that up to 25% of cancers are missed when less experienced providers perform the needle biopsies. The current recommendations, based on consensus statements, are that needle biopsy is the preferred diagnostic method, as accuracy is equivalent to surgical excisional biopsy, post-procedure complications are significantly less, and it is 50% lower in cost. The goal for needle biopsy utilization is 90%. Lymph node staging is also more accurate with the use of needle biopsy, with a false positive rate dropping from 15% to 8%. Multicentric breast cancer is more readily diagnosed with needle biopsy, facilitating decisions of lumpectomy versus mastectomy. Lastly, women can be more involved in critical decisions regarding their treatment if they're informed of the biopsy results prior to surgery. These choices include lumpectomy versus mastectomy, neoadjuvant chemotherapy, radiation therapy, and breast reconstruction. While it is likely that the rates of needle biopsy have continued to increase, that some women in the cohort did not undergo needle biopsy for legitimate clinical reasons, it is felt that improvements can be made in the use of needle biopsy for the accurate diagnosis of breast cancer, including multicentric disease and nodal status. The conclusion is that continued interventions at the surgeon level are needed so that needle biopsy utilization occurs and improvements in care are realized. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.